Hello everyone, and welcome to this lecture on approaching a patient with fever in the general practice setting. Fever is one of the most common presenting complaints in primary care. While it is often due to self-limiting viral infections, it can sometimes indicate serious, life-threatening conditions requiring urgent intervention. Today, I will walk you through a structured approach to evaluating a patient with fever, covering history taking, physical examination, relevant investigations, initial management, referral criteria, and danger signs. I will also discuss commonly used medications, their dosages, and routes of administration in the GP setting. Now, let's start with history taking. A detailed history is the first step in identifying possible causes and recognizing red flags. Assess the onset and duration of fever. Acute fever, less than 7 days, suggests infections like viral illnesses, malaria, or dengue, whereas chronic fever, greater than 2 weeks, raises suspicion for tuberculosis, endocarditis, malignancies, or autoimmune diseases. Fever patterns can also provide clues. Intermittent fever is seen in malaria or tuberculosis, sustained fever is seen in typhoid or pneumonia, and relapsing fever is also seen in malaria or leptospirosis. Evaluate associated symptoms such as respiratory complaints, which could mean viral flu, pneumonia, COVID-19, headache with photophobia, think of meningitis or dengue, rash, as seen in dengue or meningococcemia. Gastrointestinal symptoms could indicate typhoid or gastroenteritis, joint pain, as seen in dengue or chikungunya, and dysuria, pointing towards UTI, pyelonephritis. A travel and exposure history is crucial. Recent travel may suggest malaria or leptospirosis, while contact with sick individuals raises suspicion for COVID-19 or influenza. Ask about exposure to contaminated water or food, which could hint towards typhoid, hepatitis A. Additionally, review medication and immunization history to assess prior antibiotic use and vaccination status. Now let's move on to physical examination. A focused yet thorough examination is key in assessing severity and identifying red flags. General inspection should assess for a toxic appearance, dehydration, that is dry mucous membranes, poor skin turgor, and signs such as rash or jaundice, which could point towards hepatitis, leptospirosis. Vital signs are crucial. High fever, greater than 39 degrees Celsius, is seen in sepsis, dengue, bacterial infections. Tachycardia could indicate dehydration or sepsis. Hypotension is a red flag for septic shock or dengue shock syndrome. Increased respiratory rate is seen in pneumonia, metabolic acidosis. Systemic examination findings include head-to-toe examination. A systematic head-to-toe examination is essential in evaluating a patient with fever, helping to identify the underlying cause and detect any red flags requiring urgent intervention. Starting with the head and scalp, inspect for any rashes, ulcers, or scalp infections, which could be associated with systemic conditions like viral exanthems or fungal infections. Examine the eyes for conjunctival pallor, which suggests anemia, or conjunctival suffusion, which may indicate dengue or leptospirosis. The presence of icterus should raise suspicion for hepatitis, leptospirosis, or hemolysis. Photophobia and papilledema may point to meningitis or encephalitis. An otoscopic examination should be performed to look for bulging tympanic membranes in otitis media, a possible source of fever. Next, assess the nose and throat. Inspect for nasal congestion or sinus tenderness, which may indicate viral infections or bacterial sinusitis. Examine the throat for pharyngeal erythema, tonsillar exudates, or ulcers, which could suggest viral pharyngitis, infectious mononucleosis, or streptococcal infections. A strawberry tongue may be seen in scarlet fever or Kawasaki disease. Inspect the oral cavity for ulcers, which can be seen in viral illnesses like hand-foot-mouth disease or herpes simplex infection, or systemic diseases. Assess for meningeal signs, such as neck stiffness, which is a red flag for meningitis. In the chest and respiratory system, observe for signs of respiratory distress, including nasal flaring or accessory muscle use. Palpate for symmetrical chest expansion and perform percussion to assess for dullness, which may indicate consolidation in pneumonia or pleural effusion. Auscultation should focus on detecting crackles, wheezing, or reduced breath sounds, which could suggest pneumonia, bronchitis, or pleural effusion. For the cardiovascular system, assess peripheral perfusion by checking capillary refill time and pulse rate. Inspect for signs of infective endocarditis, such as splinter hemorrhages, Janeway lesions, or Osler nodes. Auscultate for any new murmurs, which may suggest endocarditis or rheumatic fever. In the abdomen, inspect for distension and perform palpation to check for hepatosplenomegaly, which can be seen in typhoid, malaria, and viral hepatitis. Right iliac fossa tenderness should raise suspicion for typhoid fever or appendicitis. Percussion can assess for shifting dullness in cases of ascites. Auscultation of bowel sounds is important, as hypoactive sounds may indicate ileus or peritonitis. In the genitourinary system, assess for flank tenderness, which may indicate pyelonephritis. Urinalysis should be performed to evaluate for hematuria, proteinuria, or puria, which can be seen in UTIs, glomerulonephritis, or leptospirosis. In males, check for any testicular swelling or tenderness that could indicate epididymo-orchitis, while in females, pelvic tenderness may point to pelvic inflammatory disease. For the musculoskeletal system, look for joint swelling and tenderness, as polyarthritis may be seen in viral fevers like dengue and chikungunya. A single swollen, tender joint may suggest septic arthritis. Persistent bone pain should raise concern for osteomyelitis or underlying malignancy. Finally, assess the neurological system. Check the patient's level of consciousness, as altered mental status is a critical red flag for sepsis, meningitis, or encephalitis. Evaluate cranial nerve function, as facial nerve palsy can be seen in viral infections. Perform a motor and sensory examination to detect any focal neurological deficits. Reflexes should be assessed, as hyperreflexia may suggest central nervous system infections or metabolic abnormalities. The presence of meningeal signs, such as positive Koenig's or Brudzinski's signs, requires urgent referral for suspected meningitis. A structured head-to-toe approach ensures that all relevant findings are considered, allowing for early diagnosis, appropriate management, and timely referral when necessary. Investigations in the GP setting include some basic investigations. Full blood count, FBC, to check for leukocytosis, think of bacterial; leukopenia, think of dengue; viral. CRP, ESR, which are inflammatory markers for sepsis or autoimmune disease. Urinalysis to assess for UTI, pyelonephritis. Random blood sugar, as sepsis in diabetics can present atypically. Specific investigations, based on suspicion, can also be orders. If suspecting dengue or in dengue endemic areas. Dengue NS1 antigen, PCR, if fever less than 5 days. Dengue IgM, IG, if fever greater than 5 days. Malaria smear, RDT in endemic, travel-exposed cases. Blood cultures for suspected sepsis. Chest X-ray for pneumonia or tuberculosis. Management of fever should be supportive and symptom-based, with appropriate medication choices depending on the underlying cause. For antipyretics and pain management, paracetamol, acetaminophen, is the drug of choice. The recommended dose for adults is 500 to 1000 mg orally every 6 hours as needed, with a maximum daily dose of 4 grams. In children, the dosage is 15 mg per kilogram orally every 6 hours as needed, with a maximum of 60 mg per kilogram per day. Non-steroidal anti-inflammatory drugs, NSAIDs, such as ibuprofen, should be avoided in suspected dengue fever due to the increased risk of bleeding. Hydration and fluid therapy are essential, especially in febrile illnesses with dehydration. For mild dehydration, oral rehydration solutions, ORS, should be encouraged. In cases of moderate dehydration, intravenous, IV, fluids such as normal saline or Ringer's lactate, 500 to 1000 ml IV over 1 to 2 hours, may be required. In dengue fever, monitoring hematocrit levels before initiating IV fluids is crucial to prevent fluid overload. Antibiotic therapy should only be initiated when a bacterial infection is suspected. For community-acquired pneumonia, the first-line options include amoxicillin, 500 to 1000 mg orally 3 times daily for 5 to 7 days, or, in cases of suspected atypical pneumonia, azithromycin, 500 mg orally once daily for 3 days. In uncomplicated urinary tract infections, UTIs, treatment options include nitrofurantoin, 100 mg orally twice daily for 5 days, or cefuroxime, 250 mg orally twice daily for 5 days. For enteric fever, typhoid, cefuroxime, 400 mg orally once daily for 7 to 10 days, or azithromycin, 500 mg orally once daily for 5 days, can be used. Skin and soft tissue infections, example cellulitis, may require flucloxacillin, 500 mg orally 4 times daily for 7 days. In selective cases, antiviral therapy may be needed. Influenza infections, if diagnosed within 48 hours of symptom onset, may be treated with oseltamivir, 75 mg orally twice daily for 5 days. For COVID-19, antiviral therapy, such as molnupiravir or Paxlovid, may be considered in high-risk patients based on current guidelines. For nausea and vomiting, antiemetic such as metoclopramide, 10 mg orally, IV 3 times daily as needed, can be used, but should be avoided in children due to the risk of extrapyramidal side effects. Ondansetron, 4 to 8 mg orally, IV 3 times daily as needed, is a safer option and can be used in children at a dose of 0.15 mg per kilogram per dose. For symptomatic relief of cough and cold, dextromethorphan, 15 mg orally 3 times daily as needed, may be used for a dry cough, while bromhexine, 8 mg orally 3 times daily as needed, is useful for a productive cough. If allergic symptoms are present, cetirizine, 10 mg orally once daily, can help alleviate symptoms. This comprehensive, symptom-based approach ensures effective management of fever while minimizing unnecessary medication use and avoiding complications. Now the question of when to refer a patient. Immediate hospital referral is required for 1. Septic shock that is presenting with hypotension or altered consciousness. 2. Severe dehydration, or with dengue warning signs, persistent vomiting. 3. Severe respiratory distress, suggesting pneumonia, COVID-19 complications. 4. Neurological signs, suggesting meningitis, encephalitis. 5. High-risk patients, which are neonates, elderly, pregnant women, immunocompromised. Urgent non-emergency referrals include 1. Prolonged fever greater than 2 weeks with no diagnosis, which could point towards TB, malignancy, autoimmune disease. 2. Recurrent fevers which suggest suspect connective tissue disease, endocarditis. A structured approach to fever involves detailed history taking, focused examination, appropriate investigations, and timely management with medications. Early recognition of red flags and referral criteria ensures optimal patient care. As general practitioners, our role is crucial in differentiating between mild and serious cases, ensuring safe and effective management. I hope this session has provided a practical guide for handling fever in the GP setting. Thank you for listening. If you have any questions, feel free to reach out.